Welcome to ADAPT NCLEX, and thank you for deciding to watch this video. Do you know how to prioritize? Do you want to know how to prioritize? Stick around. This is a recommendation from somebody who just took the test. And the way the prioritization was presented is different. New generation kind of prioritization that you get old and a new different kind. I have 3 questions. The first 2 are the old one, but the second one is the bulk of it. It has like 6 segment of prioritization segment. So stick around and let's learn something. This is it. This is classic old generation question. This is what they will ask you. Who do you see first? Do you know what to do? Do you know what is the best way to do this? You have to be sharp. And what does that mean? That means you're taking care of somebody with a breathing problem, somebody with electrolyte problem, somebody with sepsis or shock, somebody with hypothermia or hypoglycemia, somebody with what? Airway issue, which is number 1, and what? Somebody with lethargic, somebody with pain, but pain associated with lame life eyesight. And those are the patients that when you do that, you are being sharp. That is all what this be sharp means. Then you ask yourself, test taking skills. What is the question you're asking you? Who do you see first? Okay, who do you see first? 5 patients, they have the same problem. So I say GBS, what is that? It's ascending paralysis. You got to bring your content. So you start with your weakness from your leg. You go to your knee, to your waist, to your abdomen, your upper extremities, and your airway. Right? So who do you see for GB person? Think about it. Do you have a leg problem or airway problem? Knee problem or airway problem? Waist problem or airway problem? Bladder or bowel problem or airway problem? Upper extremities weakness or airway? As you can see, when you sharp, airway is number 1. And how does the breathing airway present in this patient? Speech. Look for speech changes. Look for swallowing changes. And look for cough. If your speech is affected, speech, whatever, you can't swallow well, and you have cough, yeah, I'm worried about it. Therefore, for GBS, who do you see? Weakness? Oh, no. Bladder? No. Constipation? No. Dysphagia? Yes. Slurred speech? Yes. Inability to cough? Yes. So it's 4 to 6. Select or apply. If you think you know 2, please pick 2. Don't guess. If you think you know 3, pick 3. You have to be 100 or 99.999% sure, or 101. If you think you know 2, just get 2 out of 3. If you pick 4 here, you get minus, and you get less than the maximum, which is 3 points. So who do you see? You got to be sharp. So this is the warm-up question. Let's go to the bulk of the whole case. This is a 5 and 6 segment prioritization style question. This is it. 4 patients. A nurse is caring for 4 patients. Who do you think you want to see? Colostomy, client with colostomy 1 day, post-op, and bleeding in the back. 12 hours post-op, open reduction, internal fixation with severe leg pain, cannot rate the pain, can't even tell you if it's 101, so bad. Groaning, that means the pain is not also, you cannot distinguish it, you can pain out of proportion. Groaning and grimacing. What do you think? And a client with what? Acute appendicitis, waiting for surgery, and pain of 8 out of 10. 12 hours post-traction placement for femur fracture. Now with what? Petechia on the chest. Who you want to see? You have to be sharp, right? Colostomy, when we create colostomy, there may be some blood in the bag. Post of the 1, 2, then it start clearing off. Because it takes some time. Colostomy will take like maybe 5 days for you to have stool. So most of the time you get small blood, you know, it's sanguineous, but it's not sanguineous. I mean, you can bleed enough from colostomy and die from it. See, maybe a little bit coming out from it. So this is not that bad. Open reduction internal fixation. They filled the bone, they fixed the bone. Now we have severe, I can't tell how bad is the pain. And when I'm grimacing and grimacing, you have to know that this patient leg is about to die. I have appendicitis waiting for surgery. I have pain. This is expected. Itis, I'm expect to have some pain. 8 out of 10, it's fine. There's no evidence of peritonitis or anything that I've been told. I have traction right away. 12 hours later, now I have some petechia on my chest. What is that? Red spots in my chest. This is deadly. This is fat embolism. And these affect your brain, your skin, okay, and your lung. So we have airway problem. They're going to have confusion, and they have petechia on their chest. This guy has compartment syndrome. So this guy is going to lose a limb if you don't do anything. This guy has an airway problem. He's going to die. So who do you want to see first? B sharp. So we have multiple B sharp, but you have to go with the number one. And other, you have to think about it. So we have a little bit of bleeding here. I don't think there's too much bleeding. But this, even if there's a lot of bleeding here, we still have to worry about somebody with the airway problem. So who do you see first? Number one is this. Number two is this patient is going to lose his limb. We have usually it takes like 6 hours for the leg to be dead completely, but we don't want to wait for 6 hours. So we want to fix it. Then number three will be this before number four. So number one is fat embolism. Two is compartment syndrome before the little bleeding that we're seeing there. So who do you see first? Number four, followed by number two. So that's the first question. Now, next is caring for the same case. Highlight findings that need follow-up for this patient. So we got to highlight some things that we think we need to follow up. For the face patient, what do you think we need to highlight? Yeah, we got to figure out what is the bleeding is about. Is it a lot of bleeding, excessive bleeding, or anything like that? Yes. The second one, what do we need to follow up about? We have to go look for the leg pain and assess the patient. What is going on? You need follow-up. And all these signs, groaning, and it's all related to the, and assess the patient. Acute appendicitis, no, it's nothing. We expect the patient to have pain. If they don't have pain, we worry. But so far as they have pain, we're going in the right direction. That's what you tell yourself. You have pain, you have itis, that's good. So I'm okay with this. So we don't need to highlight it. So we highlight this, we highlight this. Okay. Now, client with 12-hour post-op traction for femur fracture with petechia. We need to highlight this. So highlight this, highlight grimacing, groaning, and severe leg pain, and a little bleeding. So this is what we need to highlight that need to follow up. Okay, so that's what it is. Now, the next is carrying the same patients, these 4 patients. List 2 complications for any of this. I've given you to that. So you can say, this is not true bleeding. So I won't say it's a complication. Patient has open reduction, internal fixation, all of the sudden severe leg pain, carrying rate and grooming. this is compartment. So we have compartment syndrome. Appendicitis, there's no complication here. And here we have what? Fat embolism. So those are complications. Appendicitis is not a complication for this. This is not a complication. It's an expected thing that will happen. So these are what they start asking. At least 2 complications for any of these patients: fat embolism and compartment syndrome. Now, indicate if the statement is wrong or correct for each patient that we have. We have 4 patients. So for the colostomy patient, I will expect some bleeding in the back post-op day 1. Yeah. So some blood is fine. So this is correct, right? I will get pain meds anytime I am in severe pain. The ORF patients. This is not right. If you are in severe pain, you should not have severe pain. We fix your this thing. If you have really, really severe pain, I'm worried something is going on. Your pain should be not that severe anymore. I will need no surgery because every time you try to fix a fracture and they have pain so severe, you know that this is not natural pain. It's something you have had complication. They shouldn't be having pain anymore because the bone is set. There's going to be some pain. You give them pain medications, but not a severe pain. They can't carry that. Okay. I will need no surgery if I experience no pain. So appendicitis patient, okay, the issue coming because there's hiatus. And the hiatus is due to the appendix. This is the appendix. If this is the appendix and it's attached to the cecum, there's a blockage here. So this is filled with fluid. And so the distension is what gives the pain. When appendix rupture, all these parts come out and go into your belly. So now appendix is ruptured. There's no pressure anymore. It's the pressure that gives you pain. If there's no pressure, no pain. Therefore, if you don't have no pain, I know you have abscess. So, or you rupture. So this is wrong. If I don't have pain, I don't need. If I experience, I will not get any surgery if I experience no pain because no, you perforated. Something is bad. Okay. So this is wrong. I will experience confusion with this complication. Yeah, classic. You go to your brain, your skin, okay, and what else? Your lung. Your brain is where they get confused. So this is correct. You see what they're trying to say? It's the same thing by presenting it in the pictorial form, trying to confuse you. I mean, it's a new thing. So they will try anything. They will take information and present it. I've told people that the test is the same. It's just pictorial presentation of facts. Either they give you a bunch of statements, you got to fish it out, or they give you this table or this short prioritization that you've been doing for a long time. You know how to do it. So it's the same thing, nothing new, but just different presentation. Investigation either indicated or contraindicated. So which of this is indicated or not indicated? For the colostomy patient, do you notify the MD? Yes, it's indicated, right? For the fracture patient, that is ORF, obtained duplex, no, he has compartment syndrome. We don't need any duplex. It's going to surgery, so it's contraindicated. Appendicitis, give them ice chips, no, it's contraindicated. They're going to go surgery. You're going to delay surgery. Fat embolism, supportive care, yes, that's the management. So this is indicated. So, like I said, new form of prioritization. Don't worry about it. Don't get scared. Sit back, watch it. Give them the facts that you know. You already know it, but don't get scared. The way they present it is the same thing they're asking you in the table form, not in the table form, this way. So just go with the flow and answer the content that you know. Just bring it on. And if you need help, ADAPT NCLEX is your boy. Last one. Who do you see first? I told you, you have to be sharp. And I like prioritization because that is medicine. That's what we do. You prioritize, you see who need immediate intervention. And when you learn this, your test, you feel confident going into your test because you know any prioritization question they're going to ask you, same technique, I'm being sharp as much as I can. They won't tell you exactly what it is. You have to interpret the thing. And let's look at it. You can see all of them are on B sharp. A client with temperature 100.3 after influenza. So you say, okay, patient is going to have sepsis. But what? 100.3 is a what? Influenza. If I give you a flu vaccine, okay, your body will react with it. So I expect some kind of some temperature. We all react with it. A client with what? Heart rate of 115 after albuterol. You say what? Oh, it's tachycardia. They in shock? No, they're not. Okay, albuterol is a beta agonist. There's beta agonist in your heart, in your vessels. So beta albuterol will go and bind the one on your heart, even though it's providing bronchodilation in your lung. It has receptors, okay, on your heart. Okay, and when it binds to the one on your heart, it's going to increase your heart rate. It's an agonist. So it does what agonists do. Agonist stimulates, so it stimulates you. So I'm not seeing this patient. Client with excessive swallowing after what? Tonsillectomy. Why would you swallow if they give you, they remove your tonsil? Remember, the tonsil sits here like that. And your epiglottis sit here, and your airway is here. Your esophagus is down here behind it. When they remove your tonsil, whatever is here, any bleeding will come here. And when it come here, you swallow it. You keep on swallowing. So clearing of your throat, one, clearing of the throat and excessive swallowing is an indication of what? Bleeding. Once again, when anybody with tonsillectomy that try to clear their throat multiple times, or they have excessive swallowing, that means they're bleeding. They're bleeding, so they swallow the blood so that they don't get choked. And they clear their throat in order to prevent what? And get rid of the fluid bleeding from going to their lungs. So this patient, I know, is bleeding. But like I told you, it's a B sharp. They're not going to tell you, oh, a client with tonsillectomy is bleeding. No, they give you excessive swallowing. You have to interpret that as bleeding. That's B sharp. Client with calf pain after pelvic surgery. Ask yourself, I went to your pelvics. Okay, and your leg is here. I never touch your leg. We fix the surgery here. And all of a sudden, you have calf pain. Yeah, this is not good. This look like DVT, especially one of the risk factors for DVT is pelvic surgery. Pelvic surgery, pelvic surgery, pelvic surgery. And then you have calf pain. This patient has DVT. DVT is what? It's a breathing problem. The emboli go to your lung and become pulmonary embolism. And this is a problem. So we have a breathing problem. And then we have a bleeding problem. What do you think? Your breathing is related to your airway and you bleeding. I can give you some blood, but when you're not breathing, you die. So airway breathing always take precedence. So I have a bleeding issue, I have a DVT, and then yeah, and those two are problem. So, but the most serious one is our patient with the DVT, which will turn into a pulmonary embolism. And so I'm going to see this one first, number 4. So this is the way you do prioritization. Straightforward question. If you know the content, this is like playing checkers. You figure it out. You know that this is a trap. There's a bunch of traps. The first 2 are traps. And you stick with your gun and keep on going down, and you'll be able to see the right answer without any problem. This is how you do prioritization. If you need more, check ADAPT NCLEX, subscribe, and put your notification on. That is the only way you will know if I send this video. Trust me, if you really want to pass your exams, just check ADAPT NCLEX, free of charge. No problem. Have a great day and all the best of luck. And never stop charging. Take care of yourself.